Good evening. I'm Sonu Jain at the University of Cincinnati. I'd like to welcome you to a special webinar by the American Association for Hand Surgery and the American Society of Plastic Surgeons as part of our hand-in-hand series of collaborative webinars. We truly have world-renowned faculty tonight bringing you the cutting edge of plastic surgery, meeting hand surgery. Today we'll discuss autologous fat grafting in the upper extremity for upper extremity conditions, what you need to know. I'd like to give special thanks to Harvard Chim to help coordinate this with the ASPS. And now I'd like to introduce our moderator, Dr. Jennifer Waldry from the University of Michigan, soon to be Indiana University. Jen, why don't you take it away?
Sounds great. Thank you all so much for being here with us tonight. We're really excited to welcome this very esteemed panel of experts on fat grafting, and particularly to the upper extremity. So we have a wide range of topics tonight that I think will reach from the fundamentals of fat grafting all the way to the most nuanced aspects of this. And Dr. Peter Rubin will start us off tonight speaking on the principles of fat grafting. Dr. Rubin is the chair of the department and a professor of bioengineering at UPMC and the director of UPMC Wound Healing Services. He is an internationally well-renowned expert on adult stem cell tissue engineering derived from fat tissue, and the co-director of the Adipose Stem Cell Center at UPMC. Dr. Rubin, thank you so much for being here tonight, and please take it away.
Great, thank you so much. Let me make sure I can get my slides up. Okay, great. Can you see my slides?
Yes.
Okay, fantastic. So thank you so much. I'm really honored and privileged to be here with you for this webinar. And my world is really all about fat, not so much about hands, but I'm going to talk a little bit about some of the principles, scientific principles around fat grafting that will set the foundation, if you will, for some of the other talks, and maybe make some sense of the scientific rationale. But I will also talk about a few interesting cases that I've done with fat grafting for the upper extremity. My disclosures will mostly not affect the content of my talk tonight, but I am an investigator for GID Bio, one of their site investigators that uses stem cells for osteoarthritis. So when we talk about fat grafting, we're all very familiar with the structural component of fat tissue, the connective tissue, the adipocytes, the vasculature that provides that structural support. And in fact, in the eyes of the FDA, from a regulatory standpoint, that's the only thing that fat is good for in the eyes of the government is padding and volume and support of surrounding tissues. But there's a biologic engine within fat tissue, and that biologic engine is the adipose stromal cell or stem cell. And these are the non-lipid laden multipotent cells that we find within adipose tissue, and they're very much in the connective tissue. So these are stromal cells. This is a photomicrograph of a blood vessel with CD146 stained on the inside ring. Those are really the true parasites, and stained in red, encircling the vessel and streaking out into the stroma are CD34 positive, 31 negative labeled cells. And those are the cells that we think are the most potent in terms of their biologic activity, both in terms of plasticity, but also, very importantly, in terms of a secretome that can impact the local and even distant environment. And this is a descriptive functional matrix that I like to use to talk about adipose tissue and how we can use that in reconstructive surgery and regenerative medicine. And this really has the three components, the three effects of adipose, and those are volume and structural support, which we're all very familiar with from fat grafting and from flap surgery, but also the plasticity, which I'm not going to talk much about tonight because that really is far afield from useful clinical applications, but the secretome effects are very, very important. And these secretome effects are carried forward by the adipose stromal cells, even when you're doing fat grafting, and accounts for a lot of the biologic effects of fat grafting beyond structural support. And what can these things do? Well, they can resolve fibrosis, radiation fibrosis or scar fibrosis. And this is a paper that we published in Stem Cells, where we devised a rat hind limb model that can be a proxy. The joint motion, the range of motion in the hind limb is a proxy for the degree of fibrosis. And with both fat grafting and adipose stem cells, either or, we can greatly mitigate, prevent, and even reverse severe fibrosis in this model. The other very important effect of these cells is in the area of immunomodulation. And we've done a lot of experimental work in hind limb transplant models with rats and even swine using adipose stem cells to help tolerize the animal. But the flip side of the immunomodulatory effects is that we can use that to quell osteoarthritis. And we've been a site investigator at Pitt, one of 10 sites, working with a company, and I have no financial interest in it. We're just a study site that separates adipose stem cells for knee osteoarthritis. And in their initial phase 2B randomized controlled study, they had really very encouraging effects. And the one thing to understand with any treatment of arthritis is that there's a very significant placebo effect. So even saline or LR can have a very significant placebo effect. But with higher cell dosing, there was a dose response curve using 15 million and 30 million cells on pain scores long term in the patient population. So that sort of lays a foundation for a lot of work that we're doing in fibrotic conditions, pain conditions, and also arthritic conditions. And then there is the well-known issue of fat resorption, and that fat volume, despite putting in a certain volume, we're always going to have fat resorption. So this is a craniofacial patient that we treated in one of our DoD trials only with fat grafting, and this is 9 months after the second stage. But what the study allowed us to do was to methodically map out the graft volume over time. This is, of course, specific to the craniofacial region, but it's a good indicator of what we see in other regions as well. And we had a protocol where we could do high resolution CT scanning and volumetric analysis at different time points, immediately post-op, and then at 3 months and 9 months. And what we see is that in this case, about 63% of the fat of that volume initially injected will remain, and it tends to stabilize at about 3 months. But very importantly, the response is not uniform in all patients. That we see good responders and we see poor responders, and that really speaks to some inherent biologic properties of the fat tissue, patient to patient, that can make a difference in the performance of the fat, both for grafting but also for regenerative applications. And we've all heard about nanofat and microfat and all kinds of catchy, gimmicky names for different fat preparations that will that people really hang their hats on. The most important thing to know is just that when we harvest fat, we have particles of fat that are about 3 to 5 millimeters in diameter, and all of this is just mechanical processing. And there are a bunch of different ways. There are only a limited number of ways you can do that. You can centrifuge, you can bead mill, you can use lord-to-lord transfer, filter, mincing, chopping, enzymatic digestion or ultrasonic cavitations. Everything you see that's called nanofat or microfat or mini fat or you name it, whatever you want, is just some variation of these different processes, either alone with different parameters or in combination. And then once you get to an actually separated cell product, these are very heavily regulated by the FDA. So that's, outside of the bounds of anything that can be done except under an IDE or an IND protocol. But mostly anything that you do that contains these fat connective tissue or fat components will also contain these adipose stromal cells, and that makes the graft useful biologically. And then, by the way, this is nanofat. And it's really just an emulsion like mayonnaise, and you can break the emulsion. And we did this in a hot water bath, and you can actually separate all the oil and then have just that fibrous connective tissue component if you want to use that. So what do I do for processing? Pretty simple, very small volume, like 4 to 10 cc's, 2 to 10 cc's. I'll telfa roll because it gives you a very nice dehydrated fat. Moderate volume, like in the face, 10 to 50 cc's, or hands, aesthetic hands, I'll do Coleman technique and centrifuging. And then large volume, today I did 800 cc's total grafting in a breast aesthetic case. I'll just decant and separate the layers and do a second decant in the 30 cc syringe. So you really have to tune this to your workflow. So I'll show a few hand cases of my own. Aesthetic rejuvenation of the hand. This is really a great thing. Patients really love this, and it's very simple and easy to do. I mark out the dorsum of the hand where the veins are really prominent, and I will often go onto the dorsum of the thumb and the digits. And I use a single insertion point at the wrist crease with a long cannula, and you can cover the entire hand with this. And you use actually a fairly large bore cannula, and the veins will just bounce out of the way. I haven't had issues with hematoma. And the interesting thing is that this is actually a fair amount of fat that you have to use for this, around 25 to 30 cc's. And you can see how nicely it disguises those veins. And some of these patients, you may have to come back and do a touch-up. But you have to plan on using about 25 to 30 cc's per hand. It's not a small amount of fat to get there. And you can also very nicely massage the fat in and into the crevices. But here's a patient 3 months and 15 months later. So it does hold up 3 months and 15 months later. So you can really make these patients very happy. Here's a fingertip injury I'll show. Broken glass, laceration with retained foreign body and infection, already had operative exploration by another surgeon. He was an MD PhD student and working on his thesis, and he was having trouble working on a keyboard because of pain and tenderness in that digit. Here, this photo is a little dark, but it shows the defect a little bit better. And grafted him. It's about 2 cc's, and you really have to struggle to get 2 cc's in there, and they stay swollen for quite a while. He had a second treatment at 10 months. We got a little softening. Sometimes you have to soften them up and then come back and do some more. And this was 4 months after the second treatment. And here he is 5 years. You can see that long finger, a lot more pulp, a lot more soft tissue on the volar pad there, and a lot more comfortable working on his computer and doing the things that he wants to do. And here's kind of a oblique or lateral view, angled view, again showing that third digit out at 5 years, and he's still got some scar, in there, but a lot more soft tissue and a lot better functional outcome. This is just showing that he had the nail bed intact. Here is a really interesting case. This was a guy, an NIH scientist, who was working as snowblower, and yeah, we all know that story. And he had some bony loss on his digit as well. And he came to me and wanted. This was at a time when we were using a lot of matrix particulate ECM And that was really, popular to put on these fingers. ACell was working with us, and we started debriding and treating and debriding and treating. We debrided him, a bunch of times and put that powder on, and then actually got a nice healed wound. And he said, "I want more. What more can we do?" And I said, "Well, let's fat graft him." And here he is on the table with the fat grafting. But the interesting thing is we actually gained length, somewhere around 6.8 millimeters on that digit, measuring from the DIP joint. And here he is fat grafted, and here he is healed up. This is about, I think about a year later, and actually, had a much more functional fingertip, and he was really, really happy with it. I'll talk a little bit about a stem cell case. This was done under FDA trials. We were really treating lower limbs for pain, but this is one of our wounded warriors who also had this hand injury. He was a bilateral amputee and needed this hand to push his wheelchair. So we had that first web space contracture, a really thick, densely adherent skin graft, and we treated that. We put a high dose of adipose stem cells under that skin graft with a thin layer of fat. Got really nice supple tissue that went from being like cement to being flexible, and opened up that first web space enough that this was really important to him to be able to hold his coffee cup in that hand, hold a Starbucks in that hand. But we got some nice results with that. Other fun upper extremity case types that I've done that I'm not showing now, but just the kind of the range of stuff I see: aesthetic fat grafting for forearms for someone who had, big muscular upper arms and wanted his forearms to match. Aesthetic fat grafting for a biceps tear, actually injected into the muscle as well as the subcutaneous tissue. Fat grafting to soften PIP joint contracture. We're doing a clinical trial with that right now. We've done about 3 patients, and fat grafting for traumatic scar contracture in the hand. So that's kind of a little intro scientifically and a few interesting hand cases. And once again, I really appreciate the opportunity to be here with you.
Thank you, Dr. Rubin. That was fantastic. And I will encourage everyone to please put any questions you might have in the chat. We have a couple minutes for questions, so I'll kick one off and just ask you a little bit about your technique for how does that differ when you're fat grafting to the fingertip?
Oh, sure. So, I use, again, for that really small volume, I'm using Telfa rolling because I want to get very, very concentrated fat. I don't want to blow a lot of fluid into that fingertip. Using a very fine bore cannula, and I'm coming in right midline between the bundles, and with a really fine cannula, and just kind of carefully working through there. I'll have to do a little scar release sometimes too, which is kind of scary, which is why you saw a suture on the fingertip of that one patient, was because I kind of buttonholed through with that, but I'll try to do some scar release as well. And again, it's not a lot of fat that you can get in, and they stay swollen for a while, but it's, it's very satisfying when you do those cases.
Great. And we have a question in the chat about what has your experience been like in terms of having these cases covered by insurance?
Yeah, so I've been fighting hard with the insurance. I really made headway with our health system insurance company, UPMC insurance. And I would show them pictures of these hands and these craniofacial injuries. I mean, the breast, of course, is no problem, but that's in the breast recon policy. So I've gotten all of the cases I've showed, the recon cases on the upper extremity, I've gotten covered by insurance. But it's been a fight. It's been a struggle, and I keep plugging at them because it really makes a difference, especially, gosh, our head and neck cancer patients, and so we really made some headway. But I would encourage everyone to really push with the insurance companies on that.
Great. Thank you so much. Well, our next speaker tonight is Dr. David Culber. He's a professor of surgery at Cedars-Sinai Medical Center and at USC Keck School of Medicine. He's also the director of the Hand and Upper Extremity Surgery and the fellowship director of the Hand Fellowship Program. And he's going to talk to us tonight about fat grafting and PRP for thumb arthritis.
Okay. So hi, thank you for inviting me to this. And I'm going to talk to you about our experience really with two joints, with the basilar joint, and this applies to most every other joint. I'm going to talk to you about two papers that we're working on. One is with fat grafting and PRP, and then the other is going to be a study we're doing with Leniva, which is cadaveric fat, which is very interesting for basilar joints. So just to go over what the basilar joint issue is, it's really a problem with instability of the ligaments, and ultimately you get grinding off of the cartilage. And it affects the majority of our population, and the thumb is, accounts for 40 to 50% of the hand function. And when you have arthritis in the thumb, especially the basilar joint, it really affects your quality of life. There's surgical treatment, which is typically either trapeziectomy, which is considered the gold standard, but there's a lot of complications from that, including migration of the thumb instability, reduced pinch strength, and their implant failures that we all know about using some type of implant. There are a lot of papers on joint resurfacing, and I've done that with using a meniscus allograft, but they're all very invasive. So the thought was that maybe we could change the biology of a joint and fat graft it and help with the pain and arthritis. Diagnostic wrist arthroscopy, we first started off, and it it's very effective in visualizing the joint with these now new smaller cannulas, low complication rate, and you maintain the integrity of the joint, so you're not disrupting the architecture of the basilar joint or any joint that you're working on, because you're just putting in a small scope. So I think Dr. Rubin really gave a very good example of all the benefits of autologous fat grafting. And when it comes to a joint, they have regenerative potential, they're vasculogenic, they're chondroprotective and anti-inflammatory properties, and it probably improves pain from everyday life. We mixed our, in this particular study, we mixed the fat with PRP, and there's a lot of articles showing that platelet-enriched plasma, that concentration actually helps, has cytokines in it, and it also prolongs the viability of autologous fat. So they work synergistically together. In some patients, in this particular study that I'm presenting, we combine the two, but we also do it without the PRP. I'm not sure if it makes a difference or not. We're currently running a trial, a 3-phase trial looking at the differences between doing PRP, just debriding the joint, or doing PRP and fat, or doing fat alone. So we'll have a little more information in the years to come. So the purpose of this current study was to look at a minimally invasive approach through arthroscopy in dealing with basilar joint arthritis, and provide a joint sparing treatment for basilar joint arthritis. So this was a retrospective study done over a 4-year period with patients between the stage 2 to stage 4 arthritis that failed non-operative management. That includes splinting, cortisone injections. And we looked at the demographics, treatment history, functional outcomes. Pain was assessed during the VAS pain scores. And then we looked at the M1, M2 overlap in the lateral x-rays, and we had satisfaction surveys. So this is kind of like the surgical technique. Initially, when I started doing this, I put them in a thumb distraction, but it turns out it's much easier if you just put gentle traction on the thumb, and you have like a 1U and a 1R portal on either side of the basilar joint. In this particular case, we're using a nanoscope by Arthrex. I have no relationship with Arthrex. I will disclose which I should have done at the beginning, that I am on the board of the Muscular Transplant Foundation, MTF Biologics. So this is like what this is what it looks like when you do the arthroscopy, and you can see there's a lot of synovitis in the joint in slide A. Oftentimes you'll find loose bodies, which contributes to the subluxation of the joint. You can see that loose body there. And then you can see after you do like a synovectomy, that what the joint looks like in slide D. So you've removed all the inflammatory tissue and you just have the arthritis, and you can appreciate that there is really no cartilage either on the base of the trapezium, which is at 6 o'clock, or on the base of the thumb metacarpal. So, and then you could also do this for the STT joint, as well as the basilar joint. I think slide C is the STT joint. So the surgical technique, this is we put a shaver in, and that's really getting rid of all the synovitis. Because I think that's a big part of the inflammation, is just getting rid of the synovitis in the joint. And then you can see like this, you can use a grasper if you have like loose bodies in, and you can take out those loose bodies. And I think those loose bodies contribute to not only pain, but they also contribute to the joint subluxing. And then if there's joint instability after you finish, you can coagulate the joint to tighten up the volar capsule to prevent some instability, because it's that dorsal like translation of the joint, with the joint being unstable, that's also a pain generator. And then the surgical technique, I think Dr. Rubin really discussed it, but for very small amounts of fat, which we take, we just roll it out in telfa, and then we just mix the PRP and fat together with this little syringe. And usually the donor site's either the abdomen or the flanks. And we like to roll it out on telfa because you really can't put too much into the joint, but you'll see like maybe 3 to 5 cc's. And then this is like kind of the technique where we're now in the joint, and then we're injecting the fat and PRP in the joint. It's usually about like 3 cc's at the most that you could get into the joint. But I also like to put the fat outside the joint as well, and I'll show you a picture of what that does. So here you can see this is a patient who on the left side preoperatively, there's really no joint space. And then postoperatively, you can see there is a joint space at the basilar joint. And then I think really what's really impressive about fat grafting and the benefits of fat grafting is if you look at the two thumbs, the one on the left is her thumb that had nothing done. And it really, you can see that it doesn't look as nearly as rejuvenated on the one on the right. So on the one on the right, when I injected fat into the joint, I also then injected fat into the soft tissue. And it really helps make the hand look rejuvenated, and it feels a lot better. So you've got a patient happy on 2 accounts. So this is like our results of this study. There are 48 patients treated, ultimately joint, and 46 patients. This is kind of the distribution. We had no complications. None went on to needing additional surgery as of yet. And in 2 patients, we did the other side because they were so happy. And then this was their VAS pain scores. So you can see there's a really big difference in their pain scores. And this was for all types of arthritis. Surprisingly, I wasn't sure if it would be effective for stage 4 arthritis, but apparently it was very effective. And then you can see the M1, M2 overlap radiographs, which improved as well. These are for all stages, just the patient satisfaction one, which was very, very high in all of our patients for every stage. And so what we concluded is that this is a very effective technique, injecting fat into joints for the CMC joint, that it has rejuvenative potential, as Dr. Rubin referred to, especially, and that this may, in some patients, be a paradigm shift in the treatment of small joint arthritis. I think it's still in the early stages, and we'll have to see what the further outcomes as far as the different types of studies done to compare this with just doing fat alone, or injecting fat alone on itself, or if you have to do a synovectomy. There are more prospective studies underway, and I think there's a lot more to study regarding fat injecting into joints. I'm involved in a couple of projects like what Dr. Rubin was referring. We're doing it in knees now, and we're doing it in other joints in the hand, and we're running prospective studies. This is just, I wanted to refer to this article. This is an article I reviewed for PRS that's on the website, discussing a study that was done in England, looking at injecting just lipofilling into osteoarthritic joints of people without doing a synovectomy, and just doing it, liposectioning them and then injecting fat into multiple different joints, DIP, PIP, and MCP joints, and it seemed to be effective. There are only 25 joints studied in 15 patients, but they seem to do well in that study. So you could look up that review in that same study on the PRS website, and there's the link to that. I'm just going to briefly go over another study that I think is very interesting that kind of complicates this. This is using adipose allograft into CMC. So this is cadaveric fat. You might know this as Renuva, and when you inject it into the foot, or the other way of using it, it's called Leniva, and it's using this treated allograft adipose matrix injecting into the CMC joint. So these patients have osteoarthritis. They've already failed treatments. We've talked about autologous fat grafting and indications for it, and we've written a lot about it. And so the mechanism of action may be that these stem cells have, even though they're decellularized, they may have some leukotrienes in them and anti-inflammatory cells. So the benefit of this is that you don't have to liposuction them or violate another part of their body. It's something that is off the shelf that they could come in and just inject into them, like 1 to 3 cc's. So the great thing about Leniva, it's temperature stable. It preserves the natural endogenous components of the matrix proteins, growth factors, cytokines, and those are all vital to adipogenesis and angiogenesis. It's been indicated for wound healing. It's been used for cosmetic purposes as well, but it's never been injected into the joints. This is the first study that we've done this. I'm not going to go through all the science because Dr. Rubin really covered it, but the aim was to see if this was safe and effective to inject it into the joints, and would it relieve patients' pain? And this is just injecting it straight into their joint. So we used patients with CMC arthritis. We did a visual analog scale, a DASH score, clinical measurements, and we collected these measurements at 6 weeks, 6 months, and a year. So the clinical technique is that they come into the office. Under fluoroscopy, we make sure that we identify the joint, and we put a needle in the joint. We use like a 20 gauge needle. You need something enough to get the Leniva into the joint, and under fluoroscopy, and we inject between 1 to 2 cc's. We put a soft dressing on them. They wear a splint for about a week, and then that's it. So far we've done 33 patients, no complications, no radiographic evidence of progression. One patient who was an anesthesiologist who was having a lot of, just couldn't wait the 3 months, dropped out of the study. Otherwise, everyone was really satisfied with the results. These are the kind of the preliminary results. You can see everything improved: DASH scores, VAS scores, and VAS with activity. So everything was moving in the right direction. The strength improved surprisingly as well, because I think they were having less pain. So ultimately, this is just another component of this, of what you can inject into joints, that I think may or may not be helpful. I think we just need to wait for the final outcome of the study. But so far, it seems to be effective. Injecting Leniva into joints may be a good alternative to autologous fat, using cadaveric fat, at least for CMC arthritis. And so far at the 6-month follow-up, everyone had improvements. So I think that's all I have.
Great. Thank you so much. Thank you for a fascinating talk and helping us think about how we can push the envelope for managing thumb CMC arthritis, which can be difficult to have that conversation with patients in terms of more invasive treatment options that we have. So thank you very much. And I will encourage everyone to put their questions in the chat and we will respond to those. In the interest of time, I think we'll move on to our next speaker, Dr. Paul Sederna. So Dr. Sederna is the Robert O'Neill Professor of Surgery and the section head of plastic surgery at the University of Michigan. He's been my mentor in learning those techniques and how to integrate them in my practice. And so he's going to talk to us today about how to integrate fat grafting into your practice for the indications around scleroderma. So take it away, Dr. Sederna.
All right. Well, thank you, Jen, and thanks for having me on. So I'm going to discuss a little bit about our journey with fat grafting for scleroderma. And I will tell you that we did not come across this on purpose, but we have a huge scleroderma clinic here. We sort of fell into it. So I'm going to talk a little bit about how this all came about and what kinds of things we're seeing for this patient population. So before I go on, I want to disclose I'm president of Blue Arbor Technologies. We make neural control systems for prosthetic devices, but I am not going to be talking about any of this today. So no worries, no worries. So really, I know Dr. Rubin went into all the things he does around prepping his fat and everything, but I'm going to just talk a little bit about what I do as well. And I think for me, the biggest thing is when I'm fat grafting, my goal is to optimize cell viability as much as possible. And even more importantly, to optimize my cell retention so I get what I want out of the fat I put in. And so I'm going to talk about my steps each here first before I go into talking about scleroderma. So let's talk about fat harvesting first. So for me, as atraumatically as I can get the fat out of the body is my goal, so I can optimize as many viable cells as well. So I use a really low negative pressure, usually a handheld suction on a 10 cc syringe, or sometimes a Toomey syringe, and that really reduces the shear forces on the cells, and you have more viable cells. Larger hole cannula is better, so there's less shear on those cells. And then I like to centrifuge cells. And the reason I like to centrifuge is when I centrifuge, I can really optimize the isolation of cells that I get. So I centrifuge at 3,000 RPMs for 3 minutes. RPMs are not really the best measure of how much force you're putting on the cells, because obviously if your centrifuge is 10 miles in diameter, 3,000 RPMs is a lot more force than if it's 2 inches in diameter. But basically on a standard centrifuge, you have 3,000 RPMs for 3 minutes as described by Sid Coleman. Minimal trauma to the cells, and you get great adipocyte isolation. But even more importantly, you can take the ASC-rich fat if you want and use that if you're using lower volume. Then fat separation, I do what a lot of people do. I just decant the oil from the top. I get the aqueous layer from the bottom out. I wick it out. And a lot of times I will only use the ASC-rich portion of that fat, the first 2 or 3 cc's in each syringe. And then lastly, like a lot of people, making sure that we don't get big globs of fat in there, but instead do microfilling with micro cannulas. And I really like the Coleman cannulas. They work really well to allow getting the fat in there in lots of microtunnels so I can really optimize my fat retention rates. So this is the first scleroderma patient I saw for the face. She had some telangiectasia. She had a lot of tightness around her mouth and around her face. And it made sense to me that if we can do fat grafting in the breast and we can soften the radiated tissue in the breast with fat grafting, maybe we could actually impact the scleroderma patients as well. So for her, I fat grafted her face. I did 50 cc's of autogenous fat grafting like I just discussed. And this is where it got us. And when we're done, she did not look like a scleroderma patient at all anymore. And you can actually even see some of the skin changes that she had from her scleroderma got better with the fat grafting. This patient also, you see a lot of face tightening up. You see her mouth shrinking away, her lips being tight. And with autogenous fat grafting in her, you see a similar nice result in fullness. So if we can get this in the face, and some of those changes that we're seeing in the face works, then maybe in the hand. And so people have been doing fat grafting in the hand, and we've seen some images just to improve the aesthetic of the appearance of the hand. And here you see on the left, pre-op and a fat grafted hand on the right. And if you are really gentle when you're taking the fat out using handheld suction, you can isolate the better fat cells with centrifuge and use the standard Coleman technique, 10 to 25 cc's per hand. You can actually do a really nice job in rejuvenating these hands. And so this is about the kinds of volume we talk about, 10 to 15 cc's on the back of the hand, a couple cc's along the thumb metacarpal, 2 to 3 in the thumb index web space, and then 1 or 2 on the back of each finger. I have not had much success in fat grafting the hand beyond the PIP. It is so tight. And I know Peter talked about poking a hole in the skin. It would not be uncommon for a scleroderma hand fat grafting case for the cannula to go through the skin because it's just so tight. However, you can have a pretty significant impact. And so, this is another, you see the right hand has not been fat grafted yet, and the left hand does. And the left hand does look better from here to here, or from there to there. Subtle changes, but real changes that don't give away somebody's age quite as much. And even in these aging hands, the skin looks better. It's more full. You can't see their extensor tendons quite as much. Their joints aren't quite as prominent, and it looks good. So when I'm thinking about, okay, scleroderma in the face, we're making some pretty significant impacts for these patients. Their faces were looking better. Their faces were moving better. Their mouths were opening better. And then we have fat grafting for aesthetic appearances in the hand. It makes sense. Well, then maybe we can apply it to scleroderma. The challenge with scleroderma is there are a lot of things happening in a hand when you think about it. So with systemic sclerosis, you have widespread inflammation, vascular injury, tissue fibrosis, and really a lot of cutaneous fibrosis, particularly in the hands and the face. But there are lots of different forms of scleroderma that impact all or portions of the whole body. And we can see this poor woman that started off relatively normal. You see her lips slowly starting to disappear. And then you see full systemic sclerosis of her face with telangiectasias and everything. So for me, when I'm thinking about the hand involvement for scleroderma, I'm thinking really about, well, the sclerodactyly they get, the joint contractures they get, the Raynaud's phenomenon, the digital ulcers. If I had my choice, obviously, I would love to get the scleroderma hands before they are end stage. I would love to have an opportunity to bring the fat into those hands so I can prophylactically prevent some of these consequences of the disease process from progressing. That isn't always the case, but if I had the choice, I would come in earlier. And a lot of these patients, anyone that sees scleroderma patients knows they get all sorts of problems with fingertip ulcers. And when you look at their fingers, they all have clubbing. They all have shortening of their fingers. Sometimes they already have amputations before you ever see them. And it is a real problem for them. Not only are these ulcers bad and can lead to underlying the ulcers, but they're also really painful for them. And we see it, bilateral hands, and we see lots and lots of cases of it. So if even with fat grafting, if for some way we could soften up the skin a little bit and potentially even improve some of the vascularity by leveraging some of the local effects of fat on vascularity and things, you could potentially even make this better. Joint contractures are obviously also a huge problem for scleroderma patients. And I'm not sure how much better you can make those. However, I do believe that if you come in early in the disease process, you may be able to either slow the progression or maybe even prevent it. So there are a number of studies now I'd love to share with you our study. We have a prospective study going on right now looking at both faces and hands, lots of different PROMIS measures and lots of different measures of total active range of motion. I don't have that data to share with you, but in these 5 different studies, the earliest being in 2013 that had 21 hands and 13 patients, it does appear that there are some real benefits for autologous fat grafting and scleroderma. And I will say from my personal experience, the patients will tell you about the Raynaud's getting better. Some of them will wear gloves even to just go in the refrigerator at home. And afterwards, they'll say, I don't have to wear my gloves anymore to get something out of the refrigerator or freezer. Digital ulcers seem to be down, and this is supported by these studies. And so far, it looks like in our prospective study, they will be supported as well. And so there's a lot of evidence to support this. And so I think fat grafting can reduce the time to healing of digital ulcers, or maybe ultimately prevent digital ulcers. Certainly, I have heard a lot about people unsolicited telling me how their Raynaud's is better, and skin softening and improved mobility. A lot of the patients with scleroderma will tell you it feels like they're wearing really tight gloves. And when they go to close their hands, it's just really tight. And after the fat grafting, they say it's much looser and they feel like their range of motion is better. So here's a patient right here. This is different than the one I just showed you. She has had 2 finger amputations so far, secondary to her Raynaud's. And on her right hand, you see her index finger has pretty significant clubbing, and her left, or her right small finger, also has joint contractures starting. I fat grafted her hands. This is her with 25 cc's per hand. And this is only fat grafting the dorsum, and this is only doing the dorsum of the fingers to the PIP joints. So if we look at her left hand here, and we look at her right hand there, it's a pretty big difference between the two. I apologize for the quality of the photos. There's a shadow in the post-op on the right hand, but the right hand looks the same. If you could imagine, if you will, there was not a shadow there and it was a beautiful result. That's what it is. We'll go with that. This patient also relatively mild. So once again, I would say I would always prefer to see these earlier rather than later, because I don't think some of the severe consequences of scleroderma are ever going to be reversed with fat grafting. But I do believe when they're more mild, you can probably have a pretty significant impact. And we go from that pre-op to post-op. And if we look at them side by side, this is pre-op, pre-op, post-op, post-op. This is 20 cc's per hand. I think in this one, a couple of the things you see is when you look at the extensor tendons, are a little less prominent. When you look at their dorsal metacarpophalangeal joints, they're less prominent. When you look at their thumb index finger web space over their adductor, you see it's quite a bit. And their first dorsal interosseous, it looks quite a bit different. And that's the fullness from that fat grafting. Here's another case, another one. Relatively mild. She had really severe Raynaud's and she wore gloves all the time, including in the summer. Her fingers have really shortened a lot. She has a lot of clubbing. You can really see a lot of clubbing in the tip of that left index finger, but you also see the tip of her right index finger has really lost a lot of volume. And then fat grafting there to there. So pretty big difference for her. And even the skin, you look at the character and the color of the skin actually changes a lot. We do know that even if you use the SVF in fat grafting in pigmented skin, it can actually, through local paracrine effects, impact the melanocytes that are in the skin and change melanocyte function and change the color. And you really see it in these hands a lot. And that just isn't overexposure from a flash. That's actually changes in the skin. Here's another one we can see. She also has relatively tight hands, inflexible hands, lots of clubbing. If you look at her right thumb, you see how she has absolutely no volume in the pulp of that thumb. And you look at her index fingers, they're really shortening and clubbing a lot. And there she is post-op. So not a bad change at all. Here's the patient I showed you up front. She had her hands hardly worked. They were so tight and they hardly moved. And so, as you might imagine, I'm not going to show you some crazy dramatic image next of her playing the piano or something, but I did fat graft her, and this is 4 years later, and her motion hasn't gotten any worse, even though she has had lots of fingertip amputations, lots of difficulties closing her hands and everything. You can still see in that bottom image of her making a fist how much blanching she has over her index and middle finger metacarpophalangeal joints, but her motion is a lot better, and she was really ecstatic. For a patient like this, small gains are real gains. So because we saw such dramatic change in the skin in these scleroderma patients and softening, we started doing fat grafting in some of the burned hands as well. And the same kinds of things we see in radiated breasts, the same kinds of things that we see in fat grafting with scleroderma of the face and hands, we see similar kinds of things in hand burns, because thermal injuries lead to loss of subcutaneous tissue, lots of disorganized wound healing, scarring, fibrosis, and really a limit in hand mobility. Now, if somebody has a bunch of scar contractures, they need scar releases. And if somebody has really tight skin graft and they don't get the motion they need, maybe they need that removed and they need a flap or something. However, for those people that have some tightness from thermal injuries, doing autologous fat grafting for them can actually help, because we know it improves the color of the skin. It can address some of the thickness of the skin, some of the stiffness of the skin, and change some of the regularity of the scar tissue. So if we can impact that with fat grafting, potentially improve your total active range of motion of the fingers, and maybe improve their ability to perform their activities of daily living, unless they need a real operation like Z-plasties or flaps or something like that. And there are 2 reasonable studies, one in 2015 and one in 2018, looking at this, that did show pretty reasonable improvement in activities of daily living and range of motion. So there's a little bit of evidence here to suggest it. And our experience is about the same as well. This is a bad burn hand. I fat grafted it, and their range of motion improved and they felt a lot better. I don't have any data to support that. So, but at least anecdotally, it made a difference for them. Another patient, they talked about, how their range of motion was better, and their hands felt less tight. And here's yet a third one. This one's unfair because they have fingernail polish, so they look like they're a lot better off. But I can tell you that fat grafting for burns, it's really preliminary right now. But foundationally, it seems to make sense. But we obviously need a lot more studies to support this. So I will tell you that my take home with scleroderma is I think there is some good studies in literature supporting it. Our experience has been incredibly promising for these patients. We have a good study going right now. I'm excited about it. We'll have to see when we get enough patients what our results show. But I think based upon what the patients are saying, they're really happy with the outcomes, and it's definitely worth doing. So I want to thank you for having the time to share our experience with you. And the webinar has been great so far. I look forward to the rest of the talks. Thanks.
Thank you so much for a fantastic talk and for really shining a light on how much we can help patients with a really difficult disease process and make a difference in their quality of life. So thank you so much, Dr. Sederna. And I will just remind everyone that we will, if you want to put questions in the chat, all of our speakers will respond to those. In the interest of time, we'll move on to our next speaker, Dr. Roger Corey, who is the founder of the Miami Hand Center. He has been truly a pioneer in fat transfer to multiple areas areas with respect to reconstruction, specifically the breast and also the upper extremity. And he's going to share with us tonight his thoughts on using fat grafting to improve aesthetic outcomes in the upper extremity. So Dr. Corey, please take it away.
Can you hear me?
Yes.
Hello?
Yes.
Okay. All right. So I'm talking actually about regenerative hand surgery, not just simply cosmetic, because I think that was covered already by Peter and by David. But I've been doing, oh, that's not advancing. Why is it not advancing? Okay. Okay, let's see if we can advance this. Okay, all right. So my disclosures, I invented a Brava device, now it's Eve Bra, and out of necessity, I developed the lipografter, which is distributed by MTF. I've performed over 1,000 fat graft to the hand over the past 20 years for a bunch of indication, from contour to rejuvenation to mostly Dupuytren's release, and that I extended this to scar release with a procedure called PALF, which is a palindrome of a flap for percutaneous upper neurotomy lipofilling. I've been injecting fat for scleroderma and rheumatoid arthritis, and I'm really excited about fat for CMC arthritis, just like David Kulber talked about. I have a little different approach there. So the setup is very simple. I have gotten rid of anesthesiologists in our hand center. We do our own anesthesia, no blocks. So we give our own blocks, and it's all outpatients. So basically, we harvest the fat typically from the abdomen. To mess a lot, you see my fat is quite yellow, and I simply sediment it and put it in the syringes, and I have direct syringes, simple cannula, 18 gauge needle, 14 gauge needle. It's a very simple setup. It's really very useful for contour defects. You could see this is a common problem after cortisone injection in découvrant, and just simply inject a little fat in there. You could see the needle sticks of my fat injections here that's still completely healed, but you really restore the contour and the discoloration. It's a very nice way. Obviously, rejuvenation of the hand will fix the face, but the hand gives the age. And I do it a little differently than what you've seen before. As a hand surgeon, primarily, I like the tourniquet. I hate to see distended veins, and so I go with a finer cannula. My cannula is a 2 millimeter, 2.3 millimeter cannula, and I use it under tourniquet ischemia, exsanguinate the hand. I like to see that the hand is ischemic, so the veins are collapsed. I don't see any bleeding there at all. It doesn't swell too much. I make multiple entry sites, and it takes me about 15, 20 minutes to do the whole thing there through multiple entry sites. Basically, the improvement is dramatic. It's really very simple procedure. At 1 year follow-up, you've restored the subcutaneous fat. You've really have improved this perfect effect. As you can, if you have a close-up look, you could see how it tremendously improved the quality of the skin. The dermis is thicker. They feel better. Now, rheumatoid arthritis, as a hand surgeon, I do a lot of these. Really, fat grafting is the key part of my rheumatoid arthritis treatment. It's not only the ulnar drift that you correct, but the hand looks better. The hand looks better. It feels better, and a pretty hand is a useful hand. An ugly hand stays in the pocket. So it's really important to graft it. Whenever I do my MP joint repair, I add some fat in there to the dorsum of the hand, and a straight hand works better than a flipped hand. Now, I extended this to fat grafting. Why do you put that insert tissue? The fundamental thing here is that a needle will never cut a nerve. A needle will only cut structure that are tensed. It will not. I went to the anatomy lab. You couldn't cut a nerve with a needle unless there's some tension on that nerve. So I've been treated Dupuytren contracture like this for the past 15, 20 years. I have not opened a Dupuytren in the past 10 years. The trick here is under tourniquet ischemia, regional block, a very strong extension force, and basically mesh the cord in such a way that you really attrition, destroy the cord, multiple superficial nick all along the length of the cord, and then that creates a scaffold. The cord becomes a recipient scaffold for fat grafting, and then you put a bunch of fat in there. Basically, here it's done in the operating room. You have to use those old-fashioned lead hand. The little aluminum hand doesn't do it. It's not strong enough. You have to get those old lead hands there to apply a lot of tension there, and even the tightest of contracture can be released completely. And here it is at 1.5 year follow-up. Instead of cutting, removing, we actually added tissue. Instead of cutting and removing here, this is, I don't a simple wrist block anesthesia. It takes me about 15 minutes to release, put a little fat in there, and 3 weeks follow-up, and then 1.5 year follow-up, the cord is gone. You've destroyed the cord and you've replaced it with fat, and it looks much better. You could take care of the nodule this way. This is a very tight contracture with Dupuytren nodule. You put on a very strong tension, and I can see how with the needle there, basically you start more proximal. You only move distal when the proximal part has softened, and you maintain the tension. It's very important as you do this to maintain the tension. As you release it, you open it further so the tension is maintained throughout your meshing process. And then the 18 gauge needle that you build, bent 95 degrees to 90 degrees to separate in a windshield wiper effect the cord from the dermis. And here it is, completely flat, completely open. You put the fat in there. 5 days later, he's able to make a fist. 12 days later, he actually went skiing. So this is actually a multi-digital ray, as was an orthopedic surgeon, a colleague in town who knew that, you couldn't release that in one operation. You couldn't release those multiple rays in one operation. So he went to surgery here, and we did it. Actually, it was a live surgery that we did at that point, part of a course. And you could see how on the tension, I went with my needle, multiple needle sticks, and you can feel the needle releasing the cord. And you have to maintain the tension, keep it tight as you do it. Keep it tight as you do it, release it to maintain the tension, and you keep on doing it until the hand is completely flat. It takes about 5-10 minutes, but you can get to the tighter contracture to completely soft hand. Then I put a little bit of fat in there, about 5 to 10 cc's of dilute fat per digital ray. And 4 days post-op, and here he is working, and a 1.5 year follow-up, he's had a hand completely open without any incision, any scar. The return to work is much better. It's really the treatment, the ideal treatment for multiple digital ray. Dr. Hovius, a colleague, a chief of plastic surgery in Holland, has done a prospective randomized study comparing this technique to the standard fasciotomy, and he showed that the passive extension deficit, PALF compared to standard surgery was really the same at 1 year. The same thing for the PALF, for the flexor movement was also about the same, except that early on, they could flex much better. But the biggest difference is really how long it take you to return to normal daily activities. 9 days for the PALF, 19 days for the other technique. Now, this is older people, and like my dad used to say, at my age, every day counts. I said, don't knock my hand out for 3 weeks. I'd rather go back to use it early. Hovius follows for 5 years, and at 5 years in his population, the open technique was slightly better. But I did not have a 5-year follow-up in Miami. I think my patients are older. He's in the epicenter of the disease with much more aggressive disease in younger population than ours. But I tell my Dupuytren patient they have 3 alternatives. Simple needle, quick recovery, short improvement. PALF, where you add some fat, slightly longer recovery, but really very good till 5 years. And then you can do the straight operation, the fasciectomy, with a long recovery, probably long-term improvement. I could tell you, most of my patients prefer the simple one. So I've done over 600 operations of 480 patients. I don't do more open surgery for Dupuytren unless it's multiple recurrence, but even then, I don't do it. Look at the worst finger. A really 60% correction at 1 year, and MP Jones, the best you correct completely at 1 year. It's really compared to fasciotomy. The return to activity is 8 days post-op. Those patients are using their hands. There's no sutures, no wounds. They're highly satisfied. I have never cut a nerve in a primary one. Out of these, I've only cut some nerves in a recurrence because then the nerve is encased in scar, which puts it under tension when you put that when you extend it. So then extend the same principle of Dupuytren release to scar contracture release. This is a young boy with a burn scar contracture across his MP joint. We basically put in a lead hand, mesh expanded like we did with the Dupuytren, add some fat. It's completely flat. And you could see here that instead of removing it, now I have a soft scar and he completely flat the hand. This is a young boy and he lost his middle phalanx through an injury here, that the soft tissue. Now you would have done a flap here or something to release that contracture. It's already recurvaginal with the digits. And you can see how we meshed it straight open, put some fat, and you got it completely flat. So it's really, this is a more challenging one because this is a fingertip injury treated with a neurovascular advancement flap with still a persistent mallet deformity. You can see the hook here. I couldn't stretch it out, and you can't really do anything else here. But yes, I meshed that tissue. I put some fat and meshed it. I saw Dr. Rubin injecting fat in the distal phalanx. The key to not having the tension is that needle stick, because then you mesh, expand the tissue, the whole thing open. And I'll tackle more about that. But we heal across those tiny little gaps without a scar. So we have ability to regenerate across millimeter gaps. And in some of these millimeter gaps in mesh expansion pattern really regenerate a bunch of tissues there. We got it flat from here to here. So this is another burn contracture. Again, same thing, put on the tension, release it like a Dupuytren, add some fat into it, and you stretch it out, and you get it at 6-month follow-up. Some improvement, one procedure. You could do more, but he was happy. He's already improved it significantly. This is a common injury here when the flaps necrose, and you have that contraction of the digit. Even on the strong extension, that PIP does not open because of tissue deficiency here. And we can mesh it, expand it, and add some fat. Again, mesh expand, a tight contracture, completely flat. There's been no flap here. This is a PALF, a percutaneous aponeurotomy and lipofilling instead of a flap. And you can see how we get it completely flat there as compared to that tight contracture without any incision. This is an interesting patient because he had a recurrent Dupuytren, twice with Zyflex, twice a fasciectomy. He was even radiated back in California before coming to see me. And he heard about a technique. And in one operation, we got it straight by adding fat to reverse the radiation and do the treatment. This is a first web space contracture, recurrent even after radio forearm flap. That's only could open on the tension in the OR. We meshed it like you mesh a skin graft, like you mesh a Dupuytren, and you can see right there he opened much more on his own. A burn contracture, same principle, like Dr. Sedan has shown you. Basically, I put them on the tension. The key here is tension and the mesh effect of your needle. Once you mesh it, you really open it up and you put some fat and it changes the whole area. It just softens the scars and allow it to open and regenerate. So basically, instead of doing the standard Z-plasty of borrowing for Peter to pay Paul with a bunch of scars, we are mesh expanding Paul and making Paul larger. We're just enlarging Paul. So this is regenerative surgery because you can heal across these little gaps without a scar. Now, obviously, this is the best way to treat burn scar contracture. You could see how, and Paul has shown some of this. Basically, it softens the scar tremendously. Even axillary scar, we did this on the local anesthesia. He had a trach, and they didn't want me to do general anesthesia. Local anesthesia, we mesh expanded, open it up. This guy had a sharp bite to the elbow, and the orthopedist wanted soft tissue to repair his elbow joint. And you could see how I mesh expanded this in 2 sessions. I got him completely closed. The key here is no undermining, only mesh expansion, fat grafting, and approximation. The way to treat, if you want to start doing this, is very simple. You take a wound that you normally close under tension, you don't undermine, you put a bunch of needle sticks, and the tension goes away. You don't undermine, you put a bunch of needle sticks, and the tension goes away. And I apply that to the lower extremity. This is a venous stasis ulcer, squamous cell carcinoma excision. And these patients are anticoagulated. You couldn't do a flap or graft, it bleeds like hell. And again, this technique came to me out of necessity. I do a lot of cancer closure, and all these patients come to me fully anticoagulated. Lower extremity, the flaps, instead of a flap, we did a PALF here. So we can regenerate tissue. We regenerate 1 millimeter gap, and you stack a bunch of these, and you get a mesh expansion pattern that opens it up. The fat graft in the interstices, so the cicatrix becomes the matrix for fat grafting. You have to avoid wide meshing because it creates cavity and you destroy the tissue. The key here is tension. Tension will create the differential cutting ability of the needle. You will not cut a nerve if you put everything else on the tension. The nerve is not on the tension in a virgin territory. It's the fibers that prevent expansion that are on the tension, and these will be meshed expanded. Avoid excessive meshing. You gain about 30%. So to get a centimeter, you got to mesh about 3 centimeter, 30%, and you can repeat it twice. I've done 120 scar contracture that way all over the place, digit, web space, palm. You get about second operation for about 25% of them. And I do that sometimes with tenolysis. The beauty here is that the quick return to activity. I put a bandage, 1 week later, there's no incision. Go back using your hand. And there's no nerve injury in primary releases. It's very important to always use tension there, because tension is what can allow you to cut what's restricting the advancement and not the nerves. All right, so this is a kid with a this was a burn. This is an infection, actually, a septic, and it's extensor tendon. He has extrinsic tightness. You see, if under tension, I could not bring his MP joints down. He has extrinsic because the extensor tendon is stuck here, and we put some fat there, and then with that 18 gauge with a 90 degrees, I call it tenotome, which is simply an 18 gauge needle that you bend over. You get a windshield wiper effect, separate the tendon from the bone and from subcutaneous tissue. In one procedure, you basically restore the intrinsic tightness, and he's able to close his fingers. So percutaneous lipotenolysis is a nice trick because tendons, really the fat is help the gliding of the tendon. This is a palmar burst wound injury. Normally I would have put a free flap in there, highly tailored free flap, then open tenolysis. Well, we treat it like a Dupuytren. We put on the tension, we mesh expanded, we put fat along the flexor tendon sheath, and here he is before and after. He can completely flex, completely extend, and the contracture has been resolved. So it's a promising minimal alternative, simple tool, lipotumescence. I just take simple fact. I just take it. It takes 10 minutes to harvest and re-inject it. It really helps nerve regeneration. It's an adjunct to all my neuroma recurrent Dupuytren's. Even this lady in her late 50s had cable nerve graft or median nerve injury. She could not flex a tendon. The Tinel Peter rod here, I put some fat grafting, and she restored the FPL flexion, which is amazing for somebody this age with cable nerve graft or a median nerve and good Gibbs strength. So, but my most exciting part beside the Dupuytren is the CMC. We talked about the most common injury. Rationale is interposition arthroplasty. Well, why not fat for the arthroplasty? So for a long time, for many years, actually, I always inject fat in grade 1 and 2. But the problem in grade 3 and 4, there's no room. So why not expand it? I've been expanding the breast. Why not expanding the IP joint? So here's typically what I do. Again, under regional block anesthesia, no tourniquet. I put my distractor. I open up a joint space. I inject it under fluoroscopy. I mobilize it for 3 to 4 weeks. Come back, remove the distractor, and voila, we regenerate the joint space. The setup is very straightforward. I just harvest fat from the abdomen under local anesthesia. I like to telfa roll it. You put the fat. Notice I have no blood. You notice my fat is non-bloody because I tumesce tremendously. A lot of epinephrine. So I put it in my telfa roll here, and I go there and I pack it in my 3cc syringe. I like to use a 3cc syringe or 1cc syringe and inject about 3 to 5 cc's per joint, just like David is doing, mostly inside the joint under fluoroscopy. You put the distractor, you stretch out, you create space for the joint, but it's very important to restore the congruity of the joint. My few failures were because, although I restored the space, the joint was no longer congruous. And with a 3 ml syringe and 18 gauge needle, I re-inject under fluoroscopy inside the joint, and I put the splint in place. This is a distracted and reduced. Remove the distractor, 9-month post-op. There's a nice joint space. It's amazing. This, again, it's important to restore joint congruity. This is a 2-year follow-up, and I have a pseudo joint, totally asymptomatic, restored full strength. Again, so the post-op care is 3 to 4 weeks. Remove the distractor. By the way, I don't know, I didn't hear how David does for his post-op care for the CMC joint, but in my case, I like to immobilize it and maintain the distractor for 3 to 4 weeks. Then I remove it, put him in a brace, and at the 5th, 6 weeks, I allow them to return back to using their hands. And I try to get an MRI at 12 months. I've done a number of patients. There's a significant improvement in the pain scale, in the pinch strength. That's 1-year follow-up. And the space widening. I gained about 1.1 millimeter of joint space return at 1-year follow-up. They've restored acuity. I've had some failure. But the beauty here is you haven't burned any bridges. Comparing the resection, trapezoidectomy, and the expansion, I didn't burn any bridges. I have no incision. And that reduces the threshold for my patient to accept an operation. I say, ma'am, I'm not going to make any incision. I'm not going to take your bone out. I'm not going to make any cuts. There's not going to be any single suture, as a matter of fact. It's all going to be done under local anesthesia. I'm take a little liposuction there and put that. You'll never see the distractor because I got a splint there for 4 weeks. They never see the distractor. This is pin placement. I played with the type of distractors over the years. I'm still not very happy with the best distractor, but I think we have one finally that works. And this is the 12th month post-op. You have a joint space. pin placement, distraction, 12 of most up, there's a joint space. This is, again, another one, restore joint space. Now, we don't stop the process. This is a pre-op, a 6-month, an 18-month. We've lost some joint space over time, so you really don't stop the regeneration. It's not as good as the original. But the beauty here is that when we take an MRI, it does not have this signal of fat. And when I come back on a few of those, there's no fat in that joint. There's some fibrous tissue. So in conclusion, we treat this is a regenerative operation to treat a degenerative disease. I think expansion is important to restore joint congruity, to restore the joint space, and the fat then restores the cartilage. I have not tried the synovectomy, the arthroscopic technique. I simply believe in recreating the joint by distraction. A simple procedure, makes sense, you like it. And again, so I think fat graft has been a great tool in armamentarian. I've been using it for nearly 20 years now. You really apply for a bunch of application for the hand. It's something that we have neglected for many years, and it's really very useful for a bunch of things. There's not a week that passes by without me doing 1 or 2 fat graft injections, whether a release of clot contracture, a Dupuytren, a contour, an arthritis, tenolysis, or something else. Thank you for your attention. Thank you for being part of that team.
Thank you, Dr. Corey. That was wonderful. Our final speaker tonight is Dr. Ashley Pistorio. She's an associate professor and the residency program director in the Department of Plastic Surgery at the University of Nevada in Las Vegas. And she's going to be talking to us about, importantly, the safety and efficacy of autologous fat grafting in the upper extremity. Thank you, Dr. Pistorio.
Hi, thanks for having me. And thanks for everyone who's sticking it out. I know we're running a little long, but really important topics. So this is, there's not a whole lot on general fat grafting complications in hands. I think there's just limited evidence. And I think, honestly, I have not really seen anything in my hands, no pun intended, that turned out poorly. Honestly, most of this is theoretical. A lot of this is drawn from what we know about fat grafting complications in breast and body, and then also face. And so some of this may not even end up being applicable in hands. But I just wanted to, and it's not advancing, of course. Haha. Okay. There we go. Good. So I don't have anything relevant to disclose for this talk. I did receive research funding from Sonex Health. I'm not talking about anything related to the carpal tunnel and ultrasound in this talk. So some primary issues in fat grafting safety, and I'm talking more about the recipient site, not so much about the donor site. Obviously, donor site, you can have general complications like infections, and you can get some hematomas or some just prolonged leakage and things like that. We don't really consider that like a major complication. It's just we have to tell our patients about it. But I generally don't have issues with my donor sites either. In general, the overall complication rate for fat grafting, and this is taken from all data, all sites, and so this includes breast, this includes face, is about 10% total. And so you can kind of get a taste of what some of the things are that we see. Potentially, infection is obviously always a concern. Things like contour irregularities, oil cysts, fat necrosis, and then hematoma seroma, they're not terribly common. If you do larger volume fat grafting, you may run into things like oil cysts a little bit more often. The contour irregularities and asymmetry really are the most common complications. And I think a lot of this can be avoided very easily when we're talking about what we're doing with the hand, whether it's for aesthetic or reconstructive purposes. The hand we were talking about, especially in people like burn scar contractures and scleroderma, there's not a lot of space to put a lot of fat. Sometimes you don't really need a whole lot. I've literally put a CC in a fingertip before, and that's all I've needed. It's all I could possibly fit in there, and it never needed another session. But always keep in mind, sometimes these folks do need multiple sessions, and they do better with multiple sessions. Fat embolism is sort of, one of our dreaded complications. I haven't seen it in hand. I don't know if anyone who's done it has seen anything like this. And you can talk about it's more theoretical, arterial versus venous fat embolism. And then obviously if you do arterial, you're going to be looking more at things like endpoint tissue necrosis. And then the venous fat embolisms are the things that we would be the most worried about, because we know where the veins drain to from the upper extremity. So we would be worried about a pulmonary fat embolus. And then there's been a little bit of chatter about oncologic potential, but I'll give a spoiler alert. While it's been shown in animals, there really has not been shown to have any major oncologic potential in humans. So just briefly, and I apologize for this very, very boring talk without really cool pictures. I have like one slide with actually fun pictures on it. But so the most common infections are usually our skin flora, staph, and strep. We do see a lot of gram negatives, especially in breast. I have not seen, and then you can get some in face as well. I haven't had any infections in my hands. And I think even in some of the burn patients that I've done, I have not seen infections, even in the folks, that were prolonged in a burn unit and had a lot of infection issues. And I always worry about colonization. And I haven't really run into that with fat grafting. So I've been lucky so far, probably. Generally, necrotizing soft tissue infections would be very, very rare in fat grafting. And then, what do we do to mitigate, potential infections? Obviously, control patient factors, understand if your patient is immune compromised from things like malnutrition, medications, especially for autoimmune disease patients. They're on immune modulators. Folks with diabetes, they may be at slightly higher risk. But really, it's about meticulous technique more than anything. So hematoma, seroma, I don't really excessively undermine anything that I fat graft for the hand or the upper extremity when I'm doing scar contracture releases and things like that. I do avoid using an excessively sharp needle in most of what I do as far as the actual depositing of the fat graft. Obviously, if you're doing aponeurotomies or scar releases and things, you're using a sharp needle to do that. And I've done that for a few sites, and then I'll come back with a very small cannula that's blunt. And it's really more about technique more than anything. Obviously, be aware if your patients are on anticoagulants and then what you want to do as far as managing these. Some of our other folks with certain connective tissue disorders, and some of our older folks also have a little bit more vessel fragility. And so they could theoretically be more at risk. But if you're using good technique with a blunt cannula, I don't really find a lot of blood vessel disruptions that are going to be causing hematoma. And then obviously, as a couple of our folks have mentioned, I am very liberal with my use of local anesthetic with epinephrine. So you will see fat necrosis, oil cysts, and calcifications. A lot of this is started by some sterile inflammation, and lipases that are present in the blood and the tissue can start to chew up your fat. What you really have to understand is, how does a fat graft neovascularize? Similar to some of the other things that we do with grafting, different tissues, within 48 hours, you're starting to see blood vessel ingrowth, and it starts at the periphery. So if you're not doing large volumes, you don't tend to see oil cysts and also, central calcifications quite as much, because the fat actually takes at a good rate, and you don't have a huge central area that isn't taking or takes a very long time to have a chance to take. Also, the handling itself of your fat that you've harvested can definitely make a big difference. I do my best to, I actually use a lot of the Telfa for most of my fingertip stuff because I find that it's a lot less traumatic to the fat, and I'm getting that nice dehydrated fat specimen that I can just put right in. And I don't have a lot of issues with oil cysts with that either. And I will come back and sometimes ultrasound patients if I'm worried about something, and I have not seen much in the ways of calcifications or oil cysts. So for contour irregularities, again, it depends on how much you're doing. You can use your general mitigation factors for your volume control. And most of these patients, if you're putting small aliquots in and you're doing nice radial threading, you're not really going to end up with this on hands or under scars. And so there's been some conflicting evidence about whether the wash that you use or the type of infiltrate that you use when you harvest will make a big difference in creating contour irregularities. I'd say the evidence is mixed. I honestly, I use pretty standard techniques, and I haven't really had any issues when I'm doing hands. It's a little bit different, I would say, when you're doing a large volume on a big area of soft tissue where you don't have a lot of your bony and tendon structure. And you can get a little carried away, I think, with potentially injecting a little bit too much in one area. And again, adding PRP. So if we're worried about limited take and how many sessions am I going to have to do for this patient, we use small aliquots in the hands. And then, adding PRP has definitely shown some evidence that you're improving the vascularity of your graft. It does cause some increase in inflammation, but you do really minimize the early atrophy of fat, and you increase the total percent take of grafts, at least in the studies that I've seen so far. I have not started adding PRP to any fat graft yet, although I would certainly consider it. One of the biggest issues, I think, of studying this and its effectiveness has been there are many different techniques to handle collecting PRP, prepping it, and there's not really a good standardized way. And I think if we have maybe some bigger trials where folks are using the same prep for their PRP, we may get a little bit more data on that. Fat embolism, like I said, is more theoretical. It's terrifying if you think about, this can happen. You can have macroscopic, and you can also have microscopic fat emboli that can make it into vessels. If you're using a blunt cannula and you're using minimal pressure, you're using a small volume syringe, we generally don't expect this. And, obviously, if you have, like I was talking about with the arterial embolism, you would expect things like ischemia of your target tissues, and so you could potentially have an area of necrosis. The good thing is most of what we're doing in the hand, we're not hitting any major vessels. We're not filling our radial or our ulnar arteries, and so I don't expect anything major to happen. If anything, it would be a really tiny area that would probably heal rather quickly. For the microscopic fat emboli, it's more through an inflammatory cascade that can cause some endothelial damage, and then you can actually have some target necrosis from that as well. And so, like I said, I don't know of anybody who does fat grafting in the upper extremity who has had a pulmonary fat embolus, but we always keep that tucked away in the back of your head. Understand your anatomy. So on the left, this is your superficial venous network in your dorsal hand. And so we're working around all of these. But if you're using your blunt cannula and you are very cognizant of the plane that you're in, and you understand, that you're not doing like excessive undermining, you're not using a needle tip, or a lot of times if you go relatively slow, the veins just bounce off, even if they're fairly fragile. So I don't really anticipate this being an issue, but just understand the anatomy, and I'd say probably better than anybody. I find plastic surgeons and hand surgeons really definitely get the anatomy of the intricacy of the anatomy, especially on the dorsal hand. And as I already had my spoiler alert in the beginning, there is no evidence in humans that autologous fat grafting has any effect on disease-free survival, overall survival, or on local or regional recurrence of cancers for which we're doing fat grafting. And so I would say that I've seen a lot of improvement in irradiated patients. I've been able to treat a lot of contracture of tissues and a lot of the radiation damage just with simple fat grafting. And so I'm happy that this is well hashed out at this point and understood and pretty widely accepted. We still have the occasional patient that does ask about this, however. And these are my references. Thank you guys again and for having the patience to stick around for this last part of the talk. And hopefully everyone has an amazing night, and we can open it up, I guess, for questions if we have time.
Thank you so much. That was a fantastic talk, and really anchored us in the key principles and things to look out for when we're doing these procedures. So thank you so much. And I want to thank all of our speakers tonight and all of you for tuning in. I do want to say that there will be a recording and a link for this. All of the speakers that we've heard tonight, that will be sent out tomorrow. And I will just speak on behalf of all of everyone who presented tonight. We are all happy to take questions about these cases or techniques. And so please do not hesitate to reach out to any of us. And I'll turn it over to Dr. Jane for the final comments.
Thanks, Jen, for wonderfully moderating this webinar. I'd like to also thank our speakers for outstanding talks, incredible results, and really enlightening us about autologous fat grafting in the upper limb. I'd like to also thank the ASPS for the collaboration in the creation of this webinar. And finally, I'd like to thank you, the audience, for spending your night with us, and hope you'll join us next month for our next webinar with the American Shoulder and Elbow Surgeons and the Orthopedic Trauma Association. We'll be looking at acute and chronic elbow instability. You can go to handsurgery.org for upcoming details. Good night.